you've hired me as your consultant, or if you're thinking about hiring me as your consultant, you should really know my background and where I get my experience from. So on this video, I'm going to share that with you. I started off, my undergrad degree was in marketing. I got a BS in marketing from Stockton State College in New Jersey, which is now Stockton University. I got that in 1983, and I got out of, when I got out of college, I got a job in marketing working for a company called Dun & Bradstreet. They had a division that was called Reuben Donnelly, and they did advertising, and I was trained in sales and advertising when I got out of school. So I was doing that when I got offered a better job by a company that was selling cleaning chemicals to hospitals and schools, disinfectants and things like that to institutions. And I met my wife while I was working in that company. And my wife is a physical therapist, Colleen Carberry. She's a physical therapist, and she specialized in traumatic brain injury and stroke rehabilitation. So her background was to wake somebody up out of a coma and then to map new pathways in the brain around the damaged part that was damaged either by the traumatic injury or the stroke. And it's pretty interesting how they do that, and I'll talk about that in a minute. But what happened was, while we were dating, I had my career going and I was very happy with what I was doing. Not as happy as I am now, but I was happy. And I was doing well. And I had a neck injury. I've had a very serious neck injury. I was walking on the beach with my wife, and I was trying to show off. You know, we weren't married yet, so I was still trying to show off. So I jumped up on the thing they hang the lifeguard boats on, and I was hanging by my hands. And then I jumped down, and when my feet hit the beach, I felt like I got struck by lightning. Electric shock went through my body. I collapsed on the beach. I had trouble breathing, and I couldn't move. I couldn't feel anything from my neck down. I was shocked at what had just happened. I thought I might have just broken my neck and that I was going to spend the rest of my life in a wheelchair. It was a very awakening moment. But what happened was, in about a minute, I got the feeling back. Maybe it was less than a minute, I don't know. It was a pretty scary long time. But I got the feeling back, and I started to realize that I didn't break my neck, or maybe I did, I don't know, but I did something. So I thought maybe it's best if I go to the emergency room. So we went to the emergency room. My wife took me, told the doctor the story. The doctor said, "I think you broke your neck." And they were telling me that they might have to get a surgeon to drill a halo. That's a brace where they drill into your skull and fit a halo on me if I did break the neck, and they were going to take a whole bunch of x-rays and find out what I did injure. So after the x-rays, he came out with the good news, bad news thing. He said, good news is you didn't break your neck. The bad news is we don't know what you did, so here's a bunch of medication, and here's a list of doctors, and good luck. So I started off in healthcare originally as a patient, trying to solve my own problem. And I took the medication for a while. It was pretty strong medication. It was muscle relaxers and anti-inflammatories, and the muscle relaxers were strong enough that I remember I took one. It would knock me out for about 10 hours, and they had me on 3 a day. So I was just sleeping all day long, and that was not a good solution for me. So after doing that for about, I don't know, 3 or 4 weeks, I finally got the cognition, I got to do something different. It felt like there was something wrong with my neck, and I thought that the plan that the doctors had was to give me medication to make me feel better until my body fixed itself. And I can't explain it to you, but I can just tell you, I didn't think my body was going to fix itself. It felt like something was wrong, something was different, and I wanted to get it back to the way it was. So my wife's family is very pharmaceutically based, and so they did not think that going to a chiropractor was the greatest idea. But I decided I was going to go to a chiropractor, and my wife wanted to go with me to protect me because she heard not the greatest things about chiropractic when she was in undergrad school getting her PT degree. So we went, and I remember we were the only people in the chiropractic office. He had just opened his practice. It's somebody I went to school with. He was a few years older than me. He was in my brother's grade, and I knew he was a school teacher. And then the next thing I know, he was going back to school to become a chiropractor, and then he became a chiropractor. So I went, he looked at me, he said, you injured your neck, but you had an injury there before because there's degeneration there at 2 levels. And so he started adjusting me, and he fixed my neck. And I was thrilled because I knew it wasn't right, and when he started working on it, headaches went away, I had numbness in my hand that went away, pain in my shoulder went away, and I was just thrilled that he did this. So it was so eye-opening to me that I had the epiphany that I wanted to go back to school and become a chiropractor. That was the business I wanted to be in. My wife also had an epiphany, being a physical therapist, when she dealt with head injured patients. What they would do is they would load and unload the weight-bearing joints with a tilt table while the patient was still in a coma. So that would stimulate synaptogenesis. The proprioceptive nerve endings in the joints would be stimulated by the weight-bearing, even though the patient was still unconscious. And on these tables, they're strapped in. So they tilt them in the weight-bearing position, and twice a day they do this until they come out of the coma. When they come out of the coma, then they teach them how to sit up, they teach them how to stand up, they teach them how to walk, they teach them how to play catch, and it helps them to remap shortcuts around the damaged part of the brain. So when my wife looked at chiropractic, she realized that chiropractors were working on weight-bearing joints in the spine that were stuck. And she thought it was similar to putting the keys back on the keyboard of a computer. So she became a chiropractic advocate and a chiropractic fanatic. So she was all in support of me quitting my job and going back to school. I think she was the only one who was in support of me quitting my job and going back to school. I believe my father was too, but everybody else was like, you're crazy. But I did it. I went back into school. I started in 1987. I went to Life Chiropractic only because the chiropractor I went to, that's where he went. I said, where do you go? He said, Marietta, Georgia. There was good things about it and bad things about it, but I'm glad I went there. I'm sure you're glad you went to whatever school you went to. So I graduated in 1991. I worked as an associate for a year back in Pennsylvania, which is where I was living when I met my wife. And then I opened my own practice in 1992. I quickly tried to develop that practice. I had a lot of passion for what I was doing, a lot of purpose behind what I was doing. And I quickly developed that practice to grow to about 425 visits a week. Now I was only practicing 4 days a week. So it was a pretty action-packed 4 days. I was doing that by 1994. So my wife thought, you know, you're going to kill yourself working at this pace. You need to hire an associate to help you out with the volume. So I remember saying I want to hit 500, but I never did hit 500 by myself. I probably could have, but I didn't. But I hired an associate in 1995. I hired a second one in the beginning of 96. And by the middle of 1996, I was doing about 700 visits a week in that practice between the three of us. So it was a very high volume practice. There's good things about that and there's bad things about it. But the biggest takeaway I got from that experience was I noticed patients would come in and they would be complaining of whatever symptom it was, and I'm sure you see this in your practices as well, but they'd have a complaint of neck pain or shoulder pain or knee pain or whatever it was. And like a good doctor, I'd ask them, well, how long has it been going on? And they'd say a couple months or a couple years. So I noticed there was degeneration going back a couple decades. And it was kind of perplexing to me as a doctor, you know, why would these people have degeneration and not have complaints and then all of a sudden have the symptoms? And it's, you know, you know this as well as I do. Symptoms are the last thing to show up and the first thing to go away. So when I saw how massive this was, that was probably 98% of the patients, they'd have injuries they completely forgot about. And I'd say, I'm looking at your x-rays, you got injured. No, I didn't. Yes, you did. So I'd try to pinpoint, it's right here, and I'd show them on their neck or wherever it was. And I'd say, I don't know, it looks like it's about 25 years of degeneration. And then I'd get this. Could it have been 17 years of degeneration? Well, why? What happened 17 years ago? Well, 17 years ago, I was in a train wreck. Well, what happened? Well, I was in a train, I was holding on to the thing, I was riding along. I didn't know I was going to be in a train wreck. The next thing you know, I'm flying through the air, and I smashed my face on the door on the opposite side of the train. Do you think that's why I have a neck problem now? And I would always say, well, what do you think? And they would go, yeah, that makes sense. So I started realizing that's what I was dealing with, chronic degenerative problems, particularly chronic degenerative arthritis. So my wife and I started doing some research on it, and we came upon a couple doctors that were medical doctors and their research. One of them was Rene Callier. He's a physiatrist from Southern California, and he documented that when somebody injures the spine, one of the first things they do is they shift their head forward to offload the facets because that's the painful part of the spine. Even if it's L5, they'll shift their head forward to offload the facets. So what he was discovering, or what he was relaying, is a low back problem will eventually equal a neck problem. And I also observed that in practice. Seeing that high volume of patients, whenever somebody had a low back problem, they eventually developed a neck problem. Whenever somebody had a neck problem, they eventually developed a low back problem. So that made a lot of sense to us. And he coined the phrase forward head carriage. And when I looked at my patients, they all had it. So that made sense. And we found another doctor, Dr. Vladimir Janda, who is also a physiatrist from Czechoslovakia. And what he said was, if you shift your head forward, you have to use different muscles to hold your body up. And without going into a lot of detail now, he coined those phrases upper cross and lower cross syndrome. So we looked at it, we tested some of our patients for it, and everybody we tested had either upper cross or lower cross syndrome, or more commonly, both. So we recognized there was a pattern here. We recognized we could do something about it. I'm married to a physical therapist. We thought, okay, chiropractor, physical therapist, we could work on the adjustments. I could do the adjustments and break up the adhesions. She could work on the rehab and correct the postural distortions. And that was our perfect plan until we found out that in the 1990s, if a physical therapist accepted a referral from a chiropractor, she could lose her license. Chiropractors were not considered a valid referral source in the state of Pennsylvania. So we were back to square one, and we thought, well, what are we going to do now? Somebody suggested to me, why don't you hire a medical doctor and let the medical doctor write the referrals or write the scripts for the physical therapy? And I was hesitant to do that because I thought if I bring a medical doctor in, he's not only going to write those scripts, he's going to write a lot of prescriptions. And I believed, and I still believed, we're way over medicated as a country. But I entertained the idea and I thought, well, let's try it. So we put an ad out and we advertised in Philadelphia and in Pittsburgh, and we were overrun with resumes. We couldn't believe how many resumes we were getting. I remember at times we were so many resumes that we were bringing doctors in groups and having them in the waiting room and explaining the job to them, and then bringing them back one by one if they were still there to interview them. And what I kept hearing from these doctors was a tune that goes kind of like this. Most of them were family practitioners. And what they were not thrilled with was, to be a family practitioner, they would see a patient who came in with a new complaint. This is probably an established patient, so it was like a re-exam, an E&M code. The patient would come in, they haven't seen him for maybe 6 years, and now they have a new complaint, and they say to the doctor, I have blah, 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 do something about blah, blah, blah. And the doctors, to make a living, had to do about 40 or 50 of these a day, so they had to rush through the visit. And the easiest way to fix them and get out of the room was to write a prescription. And I've had a lot of doctors tell me they were sick of doing that. And I was blown away. I had no idea that that concept or that thought process even existed in healthcare. I thought all medical doctors hated chiropractors, and I found out that absolutely was not true. What I found out was that medical doctors, like chiropractors, 80% of us went to school because we had a definite desire and passion to help other people. And it's 20% of our professions that do things that get us in trouble. And they're the people that I always tried to stay away from. So what we did was we actually found 3 medical doctors, 2 part-timers and 1 full-timer. So we had 3 medical doctors on staff so that we had coverage of at least 2 doctors at any given time because of the volume we were seeing. And then we had to begin the task of creating the model that evolved into our model of today. So a couple things happened to do that. Number one, I actually had to decide on what services we were going to bring in. So the services we brought in, we had to put some criteria to it because we had people coming out of the woodwork saying, oh, you could do this, you could do that, this will make you a lot of money, you could do this. And we thought, well, the reason for us doing this was to try to help our patients. So let's try to figure out a way that we can bring services in that will help to correct these patients in a better way. So at the same time, I was researching how to legally set this up because it was very unclear on how to set it up. There's a couple concepts that I'm going to go over with you, but let me just finish this thought. So the rules we put in place for any service we do is, number one, if we bring a service in, it's got to be for the better outcome of the patient. That's very important to us. As a business person, that's very important. I hear a lot of chiropractors say, oh, I'm a business guy. I've heard consultants say this. I'm a business guy, so I don't worry so much about the treatment side. I'm more focused on the money side. Well, to me, I think that's a little bit off target. I am truly a business guy. I went to school for business. I worked in business. And anybody worth their salt who gets into a business is going to learn that business really, really well. If you're going to build ships, you'd be smart to become a good ship captain. If you're going to build airplanes, you'd be smart to become a good pilot. I happened to get in healthcare, so I became a good doctor. And I don't use that excuse, well, I'm more on the business side. I was a clinician. My job was to get patients well. My product was well patients. If you achieve that product, your patients will respect you for it, and you'll have longevity. You'll have truly an ability to continue on into the future because the patients will know that you're really in it to help people. You know that when you go to a business where you're buying something, if the salesman's interested in helping you or if the salesman's interested in helping their commission. You can sense that, and so can patients. So as a good business guy, it is my duty to be a good doctor, and that's what we put in place first. Patient outcomes are senior to anything. If we couldn't get good patient outcomes, we shouldn't be in the healthcare business. So we put effort into our care plans and the services we picked. Number two, if we bring on a service, we could theoretically get in trouble by putting services on that weren't compliant or were outside the scope or were, in violation of whatever the standard of care is. So we made sure that we did research every time we brought on a new service as to the compliance aspect of that service. So that was rule number two. And then finally, rule number three is if you go out of business, you can't help anybody, so it's got to be profitable. So the trick in this model, and the model we teach now, follows the same three rules. If you focus on money, the patients will know it, and you will probably do things for money over patient care, and that's how you get in trouble in healthcare. That's how this integrated model, I'm sure if you're new at this, you're going, I don't know if I want to do this. I hear guys get in trouble, and yes, guys do get in trouble. They get in trouble for violating those three rules. They put money ahead of the patient. It doesn't make good business sense to even do that. What makes good business sense is to have good outcomes or a good product, and our product is well patients. So that's the rules we follow. Every service we brought on was to achieve those rules. Okay, so let's talk about some of the services that we offer and how they came about in our office. Everybody understands, most chiropractors understand the value of the chiropractic adjustment. What we're trying to do is break adhesions that have formed from an area of old injury. We're going to break that down a little bit. When you have an injury, you develop scar tissue. Scar tissue comes from trauma or surgery. And scar tissue is not tissue that is as flexible as other tissue, which means it limits the motion. Now, I think most chiropractors understand the concept of imbibition of a disc, and that means as you have two vertebrae moving independently, that disc in between changes its pressure and imbibes fluid or drinks fluid in from the surrounding tissue, which is what brings its nutrients and keeps it healthy. The same is true for all weight-bearing joints. Your knee, if you don't move it, it's going to degenerate. Your shoulder, if you don't move it, it's going to degenerate. If I were to give you this example, if somebody were to come along and tape my arm to my chest and leave it there for a year, what would happen is when we untaped it, I probably wouldn't be able to move the shoulder. It would be so degenerated and dehydrated, it would have developed adhesions in that shoulder from the lack of movement. So then what a good surgeon would do is say, let's send you to a physical therapist and see if we can start to manipulate that, because when you do that, you break adhesions. Well, the same is true for all joints. So when we're dealing with chronic degenerative arthritis, which is what most of us deal with, some of us do functional medicine as well, but that's a whole separate story. But for this purpose, a physical medicine clinic is trying to stop and reverse the effects of arthritis as best we can. If you remember in the previous video, I told you that we looked at the works of René Callier and Vladimir Janda, and what Callier said was when you injure your spine, you shift your head forward. And that's what leads to upper cross and lower cross syndrome. So part of the goal would be to get the posture back. When people have chronic degenerative arthritis, they lose their posture. That posture as people get older and they start to have the head go forward and the shoulders slump around and the back starts to hump, that's very common, but that's not normal. What's normal is to be able to go through life being erect and standing straight like Jack LaLanne did. He lived to be 98 years old and he was still straight and strong and fit and sharp. That's the way you're supposed to go through life. So our process is to reverse that arthritis as early as possible. The earlier we get these people, the better. So it's a combination of chiropractic and rehab. So the chiropractic part of it, we're doing our adjustments just like we ever did. But the rehab part of it, we're doing it like a physical therapist. Remember, I'm married to a physical therapist. So physical therapists do not go 3 times a week, and then as the patient starts getting better, they go to 2 times a week, and then as they start to get better, they go to 1 time a week. That's unique to chiropractic. What physical therapists do is they go 3 times a week until they're done, because they're trying to change. They have goals that they've set, and they're trying to achieve a change. So the rehab that we do is based on physical therapy protocols. Nobody goes to a physical therapist for 15 minutes at a shot. It's usually an hour. That would be 4 units of rehab, 1 hour. That's what we typically do, 4 units of rehab, and it's 3 times a week. So we tell the patients they're going to be in the office about 4.5 hours a week, because we have to see them do the rehab and any other services they would get on that day. So the one main service we brought on was physical therapy, whether it's done with a physical therapist or somebody else who has it underneath their license to be within their scope to train on. Chiropractors in most states, medical doctors, and in a lot of states, nurse practitioners and PAs can also supervise rehab, but you have to check your individual state laws. But that's how our model is set. The patient, focusing on the patient, they need that rehab. We've come up with protocols. We're looking for tight muscles and we're looking for weak muscles. Now, in most clinics, doctors, chiropractors, physical therapists, they focus on the painful muscle. And the painful muscle is always the tight one. But what I've learned is the tight muscle is there because there's a weak muscle. It's kind of like this. If you have a bunch of guys on a football team on the front line and one of them's real weak, that's your weak spot. That's going to be where the play always goes to, because they can't hold up their end. The same is true here. If you have a weak muscle, the other team members, the other muscles, are going to try to make up for that and tighten up to do the job. So for example, if your head goes forward, you're not using your spinal erectors anymore. Now you're using more like your trapezius and your levator scap. So deep neck flexors will get weak and your rhomboids will get weak. As you go forward, your shoulders round. So as you round, what happens is you start to stretch the supraspinatus and cut off the blood flow to the distal portion of it, which is why it is the most commonly torn of the rotator cuff. If you're going to do surgery on that, you're still not going to fix the patient unless you get the shoulders back, and that requires a rehab protocol. So our protocols are to do the rehab. We do our re-exams every 2 weeks. You know, a lot of people tell me you have to do re-exams once a month. Well, the key words there is at least once a month. I believe Medicare says if you don't do your re-exams at least once a month, you're being negligent. So we re-examine our patients every 2 weeks, and we're doing what we call a functional physical exam to make sure they get better. The other thing we do is we try to break up adhesions through injections. So I read a book a long time ago by a woman named Janet Travell, and that kind of changed my opinion on how to deal with arthritis. And she was talking about doing injections, and she pointed out that a lot of doctors will use steroids for arthritic joints, and the purpose of that steroid is to dissolve the adhesions to allow better circulation and allow better movement. And that's a good concept, but the problem is the steroids are usually non-discriminant, which means they will dissolve other tissues as well. In fact, I remember reading in the physician's desk reference back in the 90s about corticosteroids, and it said one of the side effects was it obliterates, that's the word they used, obliterates the lymphatic system. Well, that's not good. So we'd rather try to stay away from cortisone whenever possible. So Travell talked about breaking adhesions mechanically through a volume of fluid, and she was talking about saline solution. And one of the main ingredients of lidocaine or some of the other non-invasive drugs, but like for example lidocaine, is 98 or 99% saline solution depending upon the strength that you get. So in using lidocaine, you get a little bit of a numbing effect, but you also have the fluid in there to break the adhesions, which is what you're trying to do. If you can get injected in there and inflate that capsule from the inside out, the capsule has the adhesions in it, and as it inflates, the adhesions break, which allows you more mobility and more flexibility. So that's a very important procedure we brought in our office. We also found that patients develop trigger points, and trigger points are when you use a phasic muscle, which is a muscle of movement, to act as a postural muscle, which is a muscle of posture. And they have different attributes and different functions. So to get a phasic muscle, which has a strong, explosive, long range of motion, to function as a postural muscle, which has a short, weak, enduring motion, because they hold a contraction, they're holding you up. The easiest way to do that is the body develops adhesions in the muscle, and that's called a trigger point. And what Janet Travell said was the worst thing to do for a trigger point was to leave it alone. Because if you do, that muscle will continue to fail, and the body will continue to compensate, and you'll go through this whole process. And according to Callier, the further forward your head goes, the more you compress your heart, the more you compress your lungs. That decreases the oxygen to your brain. It also stretches your esophagus and causes a whole bunch of bad things in your digestive tract. So we don't want that. So our goal is to get this posture back through the exercise, through the chiropractic, and through the injections by breaking adhesions in the muscles and in the arthritic joints. So it's a combination of those services. We also brace. But my wife being a physical therapist and me being a chiropractor, we do not like immobilizing braces. So we use braces that have a function, or we call them functional braces. We use knee braces that will hold the correct angle of the knee as you're rehabilitating it. If you've looked at many x-rays of knees, and there's a lot of people with knee problems, we don't just do knees, but it's one of the things we do. Knees usually degenerate medially 85% of the time as compared to laterally, which is only 15% of the time. It's much more common, but either way means that the angle of the knee and the Q angle of the femur changes. So when that changes, then you're going to have tracking issues, and you're going to have continued repetitive wear and tear processes. If you're going to attempt to correct that, one of the things you should do is get a brace that holds that knee at the correct angle. And they may have to use this brace for a long time, if not forever, but if you're rehabilitating that tissue, and that tissue can regrow itself in a natural process, you'd want to hold that knee in as natural of a position as possible so it would grow back as uniformly as possible. Plus, when you take the knee and you offload it, the pain instantly goes away. Remember, pain is the last thing to show up in any condition. So if you're not offloading that knee and they're having pain, what are they going to do? They're going to take medication, and you don't want to go down that path. So we use the bracing because we want to get the correct angle. We use decompressive braces for the low back. We tell our patients we want to use it at least twice a day. We start them off at a half an hour, and we increase it to an hour because we're trying to decompress the discs. So it's actually therapeutic and functional braces that we're using. So there's different things like that we do. There's a lot of other things you could add in if you decided that you were in an area that has a lot of allergy problems. You might want to offer allergy service because you become a medical clinic, you can do that. And allergy is usually a very natural process of building the immunity to an allergen. So it's not something that disagrees with our purpose and philosophy. We are not becoming a family practice. So we're not that we don't need family practices, but we're not going to do it because, number one, there's certain drug therapies I could never have any participation with, and that would be opioids or antidepressants. And I wouldn't want to practice that would prescribe those things. I'm also not a big fan of cholesterol medication or blood pressure medication. People do need those meds at times, but if that's your only plan, you're not going to fix the heart. So, we leave that to the family practice. What our wheelhouse is we are correcting chronic degenerative arthritis and the associated postural distortions that arise from it. So that's what we look to correct, that's what we look to do. These are just some of the services we offer to do that. There's a lot of other things we put in place, but all of them meet the 3 rules: good for the outcome of the patient, compliant, and then profitable. Thanks.